Kind of embarrassed about the video, but that's okay.
No, you're good, man.
Um, okay, so it's a huge honor to be here, and I thank you so much to Eric for the invitation. So I'm Peter Chalmers. I'm one of the shoulder neurosurgeons at the University of Utah in Salt Lake, and I wanted to talk about reverse biomechanics. This I think is a very interesting concept and topic, and the reason why it's so interesting, of course, is because it's a non-anatomic arthroplasty. And everything else we do, the biomechanics are simple. It's like make it look the way that it was before it tore, and it should be good. But this is a non-anatomic arthroplasty, so there's really a lot that may not be optimum to just make it exactly the way that it was before. So to really get into the topic, I wanted to dive a little bit into the history. So historically, there were many attempts at reverse arthroplasty. This is a picture of what's called the Kessel prosthesis. There were multiple arthroplasties that looked like this. There was one called the Fenlon. There was a near design that looked like this. And all of them failed on the glenoid component side because there was basically loosening on the glenoid component side. And it wasn't until Grammont that we really arrived at a concept that fixed that. And Grammont's original concepts were medialization of the center of rotation. And the idea behind that medialization was that and you can see that through this picture, by aligning the center of rotation with the fixation point of the implant, you reduce the amount of shear forces on the implant. And that's FS shown in the picture there. So a medialized center of rotation was thought to be really important for glenoid fixation. And there was a consequence to this, though, which was that when you had a medialized center of rotation, you had less compression from the cuff. So, so as a result, all of the early designs had a 155 neck shaft angle. So this has an obligate distalization, and the reason for that 155 was for stability. So there were actually attempts in the lab to use a medialized center of rotation at 135, and it was too unstable. So that's the reason why the original Grammont design had this 155 neck shaft angle, and the problem it had was notching. So the problem with the 155, of course, is that with that more valgus neck shaft angle, you end up with conflict between the medial aspect of the humerus and the scapular neck, and this notching it creates polyethylene debris and it creates creates wear on the scapular neck. In very severe cases, it can cause loosening of the glenoid component. It's pretty clear now that it also leads to worse outcomes. So, in addition, Grammont style reverse kinematics are abnormal, and this is results from a randomized clinical trial that we did comparing PT and a home exercise program, and we found that there's no difference. But one of the things that we interestingly found in this study was that the results of reverse in the study were not amazing. That the ASES scores were kind of in the 70s, that there was a pretty substantial complication rate. And interestingly enough, when I asked patients this question, would you repeat the operation? Only 76% said they would do it again. And when I looked at these results, I kind of felt like we could do better. All the patients are in this study at Vermont. So the question is, how do we do better? And I think that the answer to that lies in these four aspects. So I think if you can optimize these four aspects of a shoulder replacement, that generally the patient will do well. So you have to optimize what's happening with the deltoid. You have to get the deltoid to function well. You have to optimize what's happening with the cuff. You have to optimize the impingement-free arc, and we'll talk a little what that means. And you have to figure out how to avoid complications. And I think we know that about all surgery, that if you can avoid things going wrong, that you're always going to be better off. So we need to understand how these factors change as our implants change and their positions relative to the bones change. And if we can understand those factors and how they change, then we can hopefully optimize our implants. So let's talk about the impingement-free arc to begin with, because this is one that I think is a hot topic. It's one that we've come to a better understanding of mostly through three-dimensional modeling. So I'm sure Eric has shown you in his own practice that he's probably preoperatively planning a lot of his cases. I'm preoperative planning basically all of my cases. I think many shoulder surgeons are at this point. And when you preoperatively plan, it allows you to look at the actual arc of motion you get. The challenge is that the range of motion predictions you get from those softwares are inaccurate. And this is from a paper we published in the JAOS that shows there's really no correlation between range of motion that you clinically measure and what is software predicted. And there's a lot of reasons for this. One is that it doesn't include the scapula. And so one of the things we've done to try and fix this is to figure out what is happening with the scapula. And I know Eric's done some of this work as well. The way that we've done that specifically is with biplanar fluoroscopy. So this is the way this technology works. you have two fluoro machines. And typically when you use fluoro in the OR, it's like one continuous C. In our lab, we've actually disconnected the emitter and the intensifiers so that we can position them. And then what you do is put the subject inside of those two biplanar fluoroscopic views. You have the subject move, and then you compare the two different images to a three-dimensional model you built from CT scan to be able to build three-dimensional motion. So this is what it looks like. These are biplanar fluoro images. You can see here's one where we've actually matched the scapula to what's happening. So we can then take the 3D motion from there and get back to, once we have the 3D shape of the bone in a computer model, what are the bones actually doing? And this is important to understand what's happening with the scapula. And the problem is that then the math gets very hard. So we actually published these two papers trying to figure this out, and they're mostly just math to try and figure out how do you actually get from the motion of the bones to a mathematical description of that. And that's harder, that's easier said than done. And if you want a little to dip your toe into the complexity of this, you can use something called the Codman's paradox, which I'm sure many people have heard about. And it basically, that paradox arises from this problem where the math is, it's very complicated to describe actual motion within the shoulder. So this is, once you get the math right, though, then you can get a better understanding for when you move the arm, what's actually happening in between the humerus and the scapula. So for instance, this is from our normal subjects that we put in biplane. So this is a normal person just externally rotating their arm. And we've traditionally thought of external rotation as really just a humeral motion, which you can see, though, is that in the abducted and externally rotated, in the abducted position, as you externally rotate the arm, there's a lot of motion within the scapula. In fact, the scapithoracic contributes about 33 degrees of the motion arc here. And you can see that in vivo, too. This is one of my patients asleep, and you can see his U of U tattoo there. You can see as you rotate his arm, look at what's happening with the scapula. So there's a certain amount of this that's obligate. And the reason why I bring this up is because you have to understand this before you can understand what's happening in the reverse. So we then have tried to look at that in the reverse. So this is from a prospective study we did where we took patients with Guermont-style reverse arthroplasties, and we asked them to just raise their arm with a 5-pound weight. And one of the things we found that's super interesting is that with no weight, the reverses have less elevation at the humerothoracic articulation than controls. Once you hand them a weight, there's a certain number that can't elevate at all. In fact, in about 40% of our patients, once you handed the patients a weight, there was no motion to the glenohumeral motion, through the glenohumeral joint, and all of the motion was at scapulothoracic joint, i.e., the reverse was functioning about as well as a fusion in those 40% of patients. So to me, this is, again, further demonstration that we need to do better with reverse than Guermont to try and really figure out how to make the glenohumeral joint work with the scapulothoracic joint. The other thing we've looked at using this model is rotation. So one of the real challenges with the reverse is that generally patients don't get great interrotation motion back. So we took patients who had good interrotation and patients that didn't have good interrotation after reverse arthroplasty, and then we put them in biplane and looked at what's happening to the scapula. And what you can see here is on the left-hand side, that's the amount of scapular motion you get in between, with high interrotation, as compared to on the right-hand side with low interrotation. So you can see that a lot of the patients who do get interrotation, it has nothing to do with what we're doing at the glenohumeral joint. That has everything to do with that patient's ability to rotate their scapula to decrease the amount of conflict so they can achieve internal rotation. Part of this, I think, is also because you can, and if you look at carefully, you'll see this. As you see, as the patient comes in internal rotation in this image on the left, the coracoid is going distal. As the coracoid goes distal, we're detensioning the conjoint, allowing the arm to extend. And an important part of internal rotation behind the back is extension. Interrotation back is kind of a combined motion, and that's part of the reason I think that is achieved. But you can see that it all comes from the scapula originally. So this is another demonstration here of where is the scapula in our control patients, in low internal rotators, and in high internal rotators after reverse arthroplasty. You can see how much more retraction patients with high internal rotation are able to achieve. The other thing we found, which is interesting, and we're continuing to try and get to the bottom of, is that if you compare the humeral version of the component there's a difference in version between high and low internal rotators. And this probably has a lot to do with when you internally rotate, you put tension on the posterior cuff. So if you put your component in more relative anteversion, for you to get in more inter-rotation, the cuff has to come all the way around the side as it inter-rotates, and there's just too much tension for it to achieve that. So this to me suggests that humeral torsion may actually be an important thing for us to examine in the future. And it's not about the torsion, as you'll notice, relative to the forearm, it's the torsion relative to the cuff, which is something that we're probably not paying as close attention to in the operating room right now, that we probably are going to have to in the future if we want to optimize motion after reverse. So we got our biplane motion, and the next thing we wanted to do is figure out how can we control this experimentally. So to do this, we built this shoulder simulator, and the shoulder simulator is basically, it's a hexapod robot. The robot is we bought it from a car factory. Our PhD actually used to work in a car factory. It's a hexapod Fanuc F200 robot. It's the scapula, basically. It moves to recreate scapular motion. Mounted on top of it is the custom humerus controller, and then it has guy wires that replicate all of the muscles. And then as the cadaver raises their arm, it pulls on the muscles to create that motion. Now, our simulator is created backwards for how this typically is done. Typically in a simulator, what you do is you pull on the muscles to some predetermined tension. Like, for instance, in many papers, they'll say we pulled on each of the cuff muscles with 40 newtons because 40 newtons seem like a reasonable number. Instead, our simulator works the opposite. It creates the motion, and then the muscle tension is actually an output of the system instead of an input of the system, because the motion is what we know we need to achieve, and we have that from biplane. So again, power supply, IO, motion controls, linear actuators, and load cells that allow us to determine how much tension is going to the muscles, rigid bodies to try and track where is the arm in space, and then how do we create the motion we're looking to create. So this is an example here. This is the biplane fluoro tracking. This is the shoulder simulator trying to simulate the exact same motion. This is about 50% human speed. So then, again, as I mentioned, muscular forces become an output. Okay, so the first thing we did once we had this up and running was just put standard Grammont reverse dorsal arthroplasty on the simulator, compare between a native shoulder and reverse. And the first thing you see is the muscle forces are very different between reverse and standard. In particular, the reverse requires way less force within the anterior deltoid to elevate the arm. So again, muscle force here is an output. This is the amount of elevation achieved. You can see that to achieve 50 degrees of elevation here, we needed 40 newtons per kilogram of force in a native shoulder, whereas in the reverse, we only need 20. So this matches what we've known for a long time, which is that in the reverse, when you have no cuff, you optimize force within the deltoid, and that allows the reverse to elevate the arm, even if there isn't a functioning rotator cuff. The other thing we found is that it also optimizes forces within the infraspinatus. So that's shown here in the bottom right, where you can see, particularly at low degrees of elevation, you require less infraspinatus force to elevate the arm. Okay, so that's good because generally those are the two most important muscles for the shoulder function. The next thing we said, okay, is now that our simulator seems to function relatively as we'd expect it to function, let's start messing with what's going on inside to see if that also matches with what we think. So one of the first things we did is alter base plate inclination. So base plate inclination, I think, is probably one of the most well agreed upon factors within reverse replacement. Pretty much no one thinks that you should go for superior inclination. Pretty much everyone thinks you want neutral to inferior inclination. So we simulated that and found what we'd expect to find, which is that when you superiorly incline the base plate, you create a lot more shear force. And when you inferiorly incline the base plate, you create a lot less shear force. And that's shown in the graph that's on the, it's shown as B on the left. You can see a huge difference in shear force. The interesting thing, though, is that inclination does not really have much effect on muscle forces. So this is because we tried to recreate the same center of rotation, and that's also, I think, expected. So again, the benefit to us of the simulator is it allows us to measure forces inside, what's happening on the backside of the components, forces in the muscles, and then at the same time, to put it in reverse and then modify things within it to try and see, is this doing what we think it's going to do? And then from there, can we experiment on things to understand how to optimize the reverse? Okay, so a lot of that so far really is background. This is where we really get into the how do we modify the reverse to be better? So again, hopefully I've laid out for you, this is the problem, reverse isn't perfect. These are the tools we have. We have biplane to track the motion. We have our simulator to try and recreate that motion and figure out when we mess with the reverse, what's better or worse. And then we came to this question of inlay versus onlay. And this is probably one of the most hotly debated subjects within reverse design currently. There are both inlay and onlay designs on the market right now, and there are proponents for both. And there are reasons why each could be better. So we set out to say, comparing an inlay and an onlay design, how does this alter the motion? How does this alter muscular forces, and which is better? So the first thing we look at is the motion that is achievable with inlay and onlay. And what we found is that you generally can get better motion with onlay. So if you look, and RTSA here is the second line on each of them, you can see that there is better elevation, better intra-rotation, both at rest and at 90 in the onlay as compared to the inlay. And that the extra rotation is kind of a wash, maybe slightly better for at 90 degrees for an inlay design. So overall, this suggests that the onlay is better for motion. And this kind of makes sense because it pushes the bones farther apart, so therefore it should increase our impingement-free arc. Then we looked at the deltoid forces and found that there's really not a lot of difference between inlay and onlay in the deltoid in the anterior, middle, or posterior heads. The differences really come when we look at the cuff. So again, just to back up, this is the amount of force that the cuff must put on the humerus to elevate the arm. And what you see is that with an onlay design, you need more subscapularis force to elevate the arm. And the same is largely true for the infraspinatus. The teres minor is also true. You need more teres minor force to elevate the arm with an inlay design than with an onlay design. So this is helpful to us. It suggests that inlay onlay is a trade-off. Onlay may be better motion. Inlay probably less strain on the muscles to create the same amount of elevation. The next thing we looked at was inclination. So this is another hotly debated topic within shoulder arthroplasty design currently. There's 135 and 145 designs on the market. Some people use 135, some people use 145. There are arguments for both. So we looked at the same thing. How does this affect the motion? And the truth is there's basically no difference in the motion. How does it affect the forces? There's basically no difference in the forces. So this is helpful to us. This to me suggests that if we want to make reverse arthroplasty design better, this particular factor is not one that is making a big difference. So we knew historically 155 is bad for notching. Between 135 and 145, it doesn't seem to make a big difference. The other thing we've looked at is trying to understand acromial stress fractures. And I wanted to spend a little bit of time on this because I think it's probably one of the most problematic aspects of the reverse. And the thing that's interesting to me about it is that we don't actually have a good agreement as to what the etiology is. So historically, it was thought with Grammont that you put too much tension on the deltoid and the tension pulled on the acromion and then the acromion broke. But more recently, John Levy has been advancing this alternative theory, this theory that there's an impingement problem, that you have impingement between the superior aspect of the humerus, kind of the superior lateral aspect, and the acromion itself, and that creates this abutment, and that abutment causes this kind of paperclip phenomenon where you bend it back over and over and over again, and eventually the acromion breaks. There's even a third theory that Galata has advanced that maybe this is a demand issue. And here's what I mean by that. So we've talked a little bit already about how depending on how you design the reverse, and again, even a reverse as compared to a normal arthroplasty, there's more or less force on the deltoid. And if you put more or less force on the deltoid, if the deltoid has to work harder, it has to pull harder on the acromion. And if it pulls harder on the acromion, that may more likely occur to stress fracture. So this is the problem. This, when you see this on a CT scan, is bad news. Generally, these patients will not do as well. And this has been shown in multiple studies. These are two of them, one from the Bogris group and one from the Exactech database. And pretty much every study, there's another one that Mark Frankel's group has published. Pretty much all of them say the same thing, which is that if you have an acromial stress fracture, that generally your function will be worse. And it kind of doesn't matter how you measure it, whether it's the constant score or the subjective shoulder value or the simple shoulder test or the UCLA score or the SES score or the simple arthroplasty score or the abduction or the elevation. It's like everything's worse. Basically, the only thing that's the same is external rotation. So I think we can all agree this is definitely bad and we should try and avoid this if we can. And there's recent evidence that really looks at this from a more empirical perspective. And what I mean by that is this, that a lot of what I've showed you of the work in our lab is more on the inductive reasoning side, which is to say that it's basic science research. It's not clinical research. But this is more on the empirical side, which is to say it's a very large data set, and then we try and figure out what falls out of the data set as a possible predictor. So this is, if you guys haven't read this, this is a really important study, and I think everyone should read it. Basically, it shows that there's risk factors for acromial fractures in cuff tear arthropathy, massive cuff tears. Both of those are cases in which there is no cuff to help elevating the arm, i.e. the deltoid has to do all the work to elevate the arm. There are some risk factors that are related to bone quality, and those are inflammatory arthritis, female sex, and osteoporosis. And those ones are ones that I think we all expected and are kind of not surprising. Older age fits into the same category. The implant risk factors are where it really starts getting interesting. What this shows is that there's greater glenoid lateral offset and a greater increase in lateralization shoulder angle is bad for acromial stress fracture risk, whereas increased lateral humeral offset is good. So lateralization on the glenoid is bad. Lateralization on the humerus seems to be good. And I think this points where the demand etiology, and I'm going to show you why I think that. So again, this is another study that shows glenoid lateralization increases the risk for stress fractures. This is work from another biomechanical lab. This is work from George Athwal's lab, where they looked at stresses within the acromion. And what you can see very clearly is that glenosphere lateralization dramatically increases and statistically significantly so the amount of stress across the acromion. So this is the best case scenario where we can get our inductive and our empirical evidence to all line up and fit with one theory. Glenoid lateralization is bad for acromial stress fracture risk. Our lab showed the same thing. So this is prior to our current simulator. We had an older simulator that was more of the traditional style. You can see this paper was published a while ago now. And what it shows is that there's basically a dose-response relationship between glenoid lateralization and the amount of deltoid force required to elevate the arm. So again, that fits well with this theory that more glenoid lateralization requires more deltoid force, that i.e. glenoid lateralization is very bad for a deltoid moment arm. But distalization could also contribute. And I wanted to show you this because this is our most recent work, and it hasn't been published yet, but I think it really fits well with what we know so far. So we did a study looking at isolated humeral distalization. And the way that works is we custom designed an implant in the lab where you can just increase straight distalization by 5, 10, and 15 millimeters. And what we found is that distalization creates the same dose-response relationship, whereas the more distalized you go, the more deltoid force, the more subscapularis force, the more infraspinatus force you must use to create the same amount of elevation. So the reason that's the case, I think, is because when you distalize, you move the center of mass farther from the center of rotation. And that's very bad for deltoid moment arm. So this is, I think, what I've learned thus far doing biomechanics, which is that if we want to optimize the deltoid, we have to reduce demand on it by preserving the cuff and distalizing less. To optimize the cuff, we should probably use an inlay component. To optimize our pinch rate arc, we have to better understand scapular motion, and we may want to consider an onlay component. So there's a little bit of a trade-off there. And then ultimately, to avoid complications, the most important of which is probably acromial stress fractures, we need to reduce our deltoid demand. So I present all this to you as kind of a framework to think about when you approach planning, when you approach the patient you're doing a reverse shoulder arthroplasty with, how do you manage all these factors in the operating room to try and create the best outcome for that patient? All right. Eric, did you want me to, I talked for a half an hour. Do you want me to talk for another half an hour? Late at night for you guys. So
This is your world. I definitely want some time for people to ask questions
yeah,
at the end. We can do it now if you want, or if you want. It
let's
is your world.
let's do it now.
Perfect. All right. Awesome. So, Peter, that was amazing. Thank you. And I'm going to open it up before I sort of ask you my own questions. So I don't know if Joanne, Kier, any of the other residents or fellows have any questions?
Yeah.
So,
Dr. Chalmers. So,
Oh,
quick question. I guess you talked a little bit, you touched a little bit about like humeral torsion and the implants in the beginning of like the talk about like if basically like internal rotation, like it really stretches the rotator cuff to internally rotate, the more you like, I guess, anivert it. How do you think like I guess the torsion actually affects, or I didn't catch this in the studies. How does that torsion of the implant do you think affect the moment arm or the deltoid, like overall? Like, does it, how you're saying, like, if you lengthen the moment arm, it causes more force overall? Like, does that, I don't know. I guess we don't understand that yet, maybe, but
Yeah, we're trying to study that. It's a very difficult thing to study, and the reason it's difficult to study is because and this is something I'm sure you already know, but if you look at just normal humans, there's about 60 degrees variation in humeral torsion. There's huge variation in humeral torsion. And part of that has to do with activities growing up. So, for instance, baseball players create they don't derotate as much because they create this external force, by pitching through skeletal maturity. But I think that's the challenge with that is that our planning completely misses that right now because you can't capture that without understanding what's happening at the epicondyles, and all of our CT scans are proximal to that. We've tried very hard to try and predict humeral eversion just looking at the proximal aspect, and you really can't. So, like, we tried with a bunch of three-dimensional modeling to capture that, thinking we could build it into pre-op planning. It just wasn't really possible. So, I think what you want to do is, this is at least what I'm trying to advocate for is, I I'm currently, when I do reverse using a long stem component, when I put in my, like, I'll make my cut and do the gland and then come back to humerus. And then when I put, like, my broach in the humerus, we usually aim for 30 degrees version, but then I usually look and try and see, when I do that, how much head is remaining? Like, how crazy does that look relative to an anatomic cut? And there are definitely patients now where I'm placing it much more anatomically. And I am hopeful that that will be better for humeral rotation. I will say we don't have the answer to that yet, and it's just been a very difficult thing to study in the lab because using cadavers, they come in with their own version. You know what I mean? So it's actually a challenging thing to study. But I do think in the future we're going to pay more attention to that. The other thing that people are talking about with humeral version, I'm sure Eric has heard this. There are people talking about matching your version on the patient's scapular protraction. So we didn't get into this in the talk either because I kind of thought it was in the weeds. But there's a lot of variation in scapular posture depending on the patient's thoracic posture. So if the patient is more hunched forward, they tend to have their scapula come around the front. And then they're even, like, if you put the glenoid in neutral version relative to the scapula, it may be pointed straight relative to the patient's chest wall. So that's, like, people are saying, well, you should change your version on the humeral side. And I don't think that's the right answer, but that's a subject of some debate as well. Eric, how are you managing that? Like, how do you manage your humeral torsion?
yeah. I mean, it's a great question. So, we do get the little snapshot of this the elbow for our condyles to try to sort of study that or try to better understand the version with regards to like what their native version is versus what we're putting in. But I mean, with that reverse, it's like, at least in my mind, it's a non-native. So like an anatomic, I match the version obviously, but for reverse, I really don't think I don't think it makes a lot of sense, especially like some of these ones that we've seen. I mean, as you mentioned, we have 70 degrees pre-op, humeral version. I mean, really, really retroverted humeruses. And it's like, man, that does not make sense. That's going to be an optimal stability standpoint for this patient. When you're dealing with it from a reverse standpoint. So I've not been. I've subtly modified it from like 20 degrees to 40 degrees to based on their version, their CT scans, but not. But have not been willing to sort of totally match their version in the extreme cases.
Yeah, I think it's a great question, though, and I think it's an area prime for further research. So, I mean, what you're doing, Eric, to collect that data is like a really critical first step.
Gotcha. I think you had a question.
yeah, no, I was just gonna. I mean, look, One of my questions was going to be maybe it would be helpful for our residents and fellows if you could describe kind of your what I would consider standard reverse. How do you decide how much lateralization you're going to do? Do you lateralize off the base plate? Do you lateralize off the glenosphere? Are you using augments on all of them to get better inclination or inferior inclination? What is your kind of go-to standard reverse for let's just say a little old lady that comes in versus maybe a large male that's got cuff tear arthropathy or something like that? Do you have a standard go-to kind of settlement? How are you determining sizing and tensioning and those types of things?
You guys want to plan one together?
That'd be great. Go for it.
That'd be awesome, Peter.
That'd be amazing. Yeah.
So first off, I mean, I should disclose here that I'm a consultant for Exactech. So that's the system that I used. I don't think that it's the only system you can achieve good outcomes with. And there's lots of systems that are good, and I routinely use other systems, but this is the one that I use the most frequently. So take that for what you will, I guess.
I was going to say, you're a distalizer, not a lateralizer, or a little bit of both.
Well, I wanted to show that to you because okay, so this is like, maybe I'll take out the implant. This is like a pretty normal anatomy kind of patient, right? 7 degrees of retroversion is actually average. This patient has no superior inclination. I will say with 7 degrees retroversion, I typically will use a posterior augment. And when I plan the reverse, this is what I'm doing, Dr. Gottschalk, and you can tell me if you disagree, but I want the base plate to be level with the bottom. I don't want it to be any lower or higher than that. And I want it to be more posteriorly, like I would rather bias it towards the back. So if I put the glenosphere on, I want there to be, the glenosphere should be at least level with the back of the glenoid, ideally maybe overhanging a little bit. So to me, this is about, when you talk about impingement-free arc, this is how I try and plan that, as I look at where is the edge of the glenosphere relative to the scapula, and how do I get that in the right spot? And then this system that I use gives you lateralization and lengthening numbers. These numbers are relative to where you started. So different systems do this differently. Like Stryker's system gives you this kind of more global lateral offset. So you can't necessarily compare between systems. For my system in general, I want this lengthening number to be 20 to 30 max. I want it to ideally be closer to 20. So for me, about 20 milliliters of lengthening is good. And then for me, this amount of lateralization looks good. So we started with about, it says 18, we're ending with about 30. We've added about plus 12. I usually like this to be a minimum of plus 6. So for me, that generally results in, as you can see, a pretty good impingement-free arc here. Again, we know this is imperfect, but that's been what I've been doing. And then the thing that I like about this system that I think all the systems will have in the near future, so this is probably only an advantage in the moment, but is an advantage in the moment, is that I can take this plan on the glenoid side to the operating room and navigate to recreate the exact same plan. And for me, that just gives me the confidence that the x-rays are going to be the same as my plan every time. So that doesn't solve your problem. I mean, it could be, if you made a bad plan, then your x-rays will look like the bad plan that you made. But if you made a good plan, then hopefully your x-rays will reflect that good plan. So for me, I like retroversion to be, you can see here, we're at about plus 7 relative to the patient's plus 8. I want inclination to be 0 or less. So I usually aim for 0 in inclination for all the reasons I mentioned at the beginning, that really neutralizes your forces across the base plate and hopefully reduces loosening. And I like, with this, you can get really, then you get a contact number that you can be happy with, and you don't need 100% contact with a reverse. How does that differ from how you're approaching this, Eric?
Yeah, no, I think that's good. I mean, the navigation idea is awesome, and I was having this conversation with the fellows earlier today. That is the future that's coming down for every implant, is this idea of navigating. We've used augmented reality, but then the robots are coming, et cetera. My issue with all this, Peter, is like I have my vision of what I want. Similar to you, inclination is probably my most important to correct. version, from an impingement free range of motion standpoint, I think is important, and obviously some inferior overhang. But what I don't know is like actually what is my ideal target and for which patients are my ideal target, right? Is my ideal target for the older lady different than my ideal target for the 55-year-old who's still trying to relive his glory days from high school? Like, what is how much lateralization should I be tolerating? How distal should I be aiming for? Is so I've for the most part converted to inlay almost exclusively, and we could have a whole conversation about that. But should I be mismatching inlay and onlay depending on the patient? And then what about 145 versus 135? So I feel like that my problem with navigation is I still think we don't exactly know our ideal targets. We know the extremes that maybe you don't want to shoot for, but I'm not sure. Do you want to get back to 0 degrees inclination, 0 degrees retroversion, or do you want to leave it a little retroverted? Or do we want to what is who do you lateralize or distalize more? And I don't know. Anyways, I think it's hard because I have my ideal plan very similar to a lot of principles you mentioned, Peter, but I'm not actually sure if that's the right answer. I'm not sure if at the moment like we know what the ideal targets are, especially from a clinical function standpoint. And yeah, and the conjoint you mentioned is fascinating because like that is the scapular probably the scapular motion probably it, helps with the conjoint and your internal rotation is your main deficit. And so how can you optimize the conjoint? Well, some of the principles you talked about actually makes the conjoint tighter. And so I don't know. It's fascinating to me, but I'm not exactly sure. I think so. What a lot of what you just said, I think is very, very similar. But we're trying to study it as you are. We're trying to better study it in our own patients, trying to figure out what are some of these goals, and then some of the intraop tensioning stuff. Like, what is your goal intraoperatively as well?
Yeah, I mean, I think that's a missing piece right now is intraoperative tension. One of the things that I wanted to I made these slides for something else, but I think they're really relevant to our conversation
Yeah,
right now. The onlay is that like the problem with inlay onlay is,
yeah,
and this is like not really reflected in the research we've done in the lab, but I think is true in application, that it's really dependent. It's inlay onlay is more of a surgical technique than it is an implant factor.
yeah,
So, like, for instance, depending on where you make your head cut, your inlay may be sitting, maybe sitting more like an onlay in the right, as whereas like an onlay may be sitting more like an inlay on the left, right? Because that changes where your component is going to sit for both inlay and onlay. And then you can have different cuts and end up with the same pivot point then, right? Like we could have two different cuts, two different components. They could function basically the same.
yeah,
It's also dependent on how far you sink down your stem, right? I mean, so like you could take the same stem and sink it down. Depending on where you put that might be inlay or onlay again by application. And it also depends on the metaphyseal geometry of the stem. Like there are some stems that are designed as inlay stems, but they have such a thick metaphysis, you actually can't get them down far enough in hard bone for them to function like an inlay. So these are just like these are different designs that are on the market right now, and you can see how differently they sit within the metaphysis. Or your stem sizing. Like if you oversize the stem, you might not be able to get down as much. So like, I mean, this is like my favorite picture. It's like, right, like this is an onlay stem, right? But like it almost doesn't, like if the stem is this large, it almost doesn't matter. I mean, like the stem is going to sit where it's going to sit because you can hit it as hard as you want. It's not going down anymore, you know? Um,
that's awesome.
so anyway, and this is obviously not, I didn't do this case. Someone sent this to me, but you know what I mean? Like, I think that's the reason why I think ultimately, like until we get to humeral navigation, it's going to be hard, and with a measure of humeral torsion, it's going to be hard for us to really put our finger on the factors you're mentioning.
Yeah, for sure. Samir, do you see this? Samir is my research or is a med student who's going into orthopedics right now. But
Yes, sir.
did you hear that? Do you hear that whole discussion? Yeah, we've been trying to better classify inlay versus onlay, but that
Yes,
was a really
sir.
good example of what I was talking about, Samir.
Yeah, so Peter, one of the things I was getting at, which you kind of alluded to, is that Eric and I don't know when we first started talking about it, but essentially we started talking about measuring the gap, like the gap balance. And so we have these little devices that Eric got the Tournier people to make that essentially measures the amount of like tensioning by distance between the glenoid base plate and like the humeral cut surface. So it's kind of nice. It kind of helps us decide how much to lateralize almost in intra-op.
Yeah, I mean, I was always
Hey, Peter,
taught,
we've had a chat about that before.
yeah, like I've been doing that not with a but not in a measured way, and I think most surgeons are doing that in an unmeasured way. You know, they put their base plate in, they bring the humerus around in intra-rotation, they see how much space is there, they decide what size glenosphere to use. And because I think that people are doing that, they're just not doing it in a measured or scientific way. And I do think that's going to be an important piece. The problem, I think, with a lot of that, though, is that it may depend, like the patient's asleep. You know what I
Yeah.
mean? It's not
Oh, for sure, right? It's relaxation of the muscles. It's
right.
Yeah.
have you ever heard of orthosensor? What they were doing in the knee and gap balancing in the knee? I'm surprised
Mhm.
that something like that is not yet available in the shoulder.
One of the things that I think has been very interesting to learn about is that, and I'm sure Eric, you've encountered this, there's heterogeneity in the soft tissue pliability of the rotator cuff. So if you look at a patient with a lot more fatty atrophy, there's not the same distensibility of that tissue. And that fatty atrophy and this is the part that's really interesting, I think. That fatty atrophy we've historically understood that to be a factor of chronicity, but that's actually only one aspect that determines fatty atrophy. What may be an even more important aspect is the patient's circulating lipid profile. So there's a fascinating paper that was just published in the American Journal of Sports Medicine, where this group from Asia, they took lipid profiles, not regular profiles. They took like intense lipid profiles. So they looked at like ApoA and like ApoB1, and like it's like a full, like not a standard lipid profile, but a more complex one. And they could use that to predict rotator cuff healing in 80% of cases, just from the lipid profile. This is an unmeasured factor in our patients, right? That really probably affects their soft tissue distensibility and what's going to happen with their muscles postoperatively. And so to me, this is like part of the future is we need to better understand the muscle. And the good news is that we have imaging on a lot of these patients, and we probably could do that with the right analysis of those imaging scans.
That's fascinating. That's that lipid profile. I know where that's like. That's fascinating. That's probably there's something to it because right there's people that get a rotator cuff tear and don't progress to fat infiltration. There's people that get a cuff tear and like 2 years later they have like grade 3, grade 4 changes. So it's fascinating. That's fascinating about the lipid profile.
But when we go to do a reverse in those patients, and there's some of that within the infraspinatus still attached, like I think that really affects probably our tension.
Yeah, for sure. I mean, definitely for sure. And then sometimes you see subscaps that like have for the most part intact, but there's like half of the upper half of it is fat, and then when you try to repair it, it's really hard to get back. Yeah, fascinating. So we've been trying to we just got a machine finally, and we've been trying to measure like using a elastography measuring like deltoid tension and that type of thing. Do you've done some really nice work and you showed a lot of that on optimizing especially anterior deltoid tension. And obviously the Cremont styles show your way to optimize it the best. And some of the people that work with me when we do a pedicle pec for deltoid, we do a Gromont style, but then everywhere else they see me doing a lateralized one. Um, are we sort of missing? We've kind of gone so far away from optimizing the deltoid because we're focused on impingement free range of motion. Like, are we missing the boat a little bit? Like, is there something that we should be doing better to optimize the deltoid besides just protecting it during surgery?
Yeah, I mean, obviously protecting during surgery is really critical, but I think what our work shows. So the thing that's interesting to me about our work is what it shows is that distalization is really, really bad for the deltoid.
Yeah.
And for a long time, there have been all this argument about distillation. As soon as our PhD biomechanics explained it as you move the center of mass farther from the center of rotation, I was like, why didn't I think of that? That's so obvious,
Yeah.
So that's I think the one thing we know about Grammont that's bad for the deltoid, but it seems like glenoid medialization is really good for the deltoid.
Yeah.
And so I don't I know that there are a lot of people moving towards this anatomic reverse concept, and I think that that really is bad for the deltoid. And I think that all the biomechanical evidence would suggest that's not, that while that may be better for the cuff, it's probably not better for the deltoid.
Yeah.
So I think that, like everything in biology, when there's is A the right answer, or is C the right answer, that B's the right answer, the answer is always in the middle.
Well, so I think that, I'll be honest, the people that I see that the most on, right, when you're trying to balance this idea between deltoid and cuff, are the reverse for fractures, right? Because those people, theoretically speaking, you're trying to get the tuberosities to heal, and then the decision of, well, right, theoretically, if you don't think they're going to heal, you would probably lateralize more. And Eric and I agree about 95%, and then the other 5% we always agree to disagree. But that's always a discussion about how much lateralization do you do in your reverse for fractures. Are you lateralizing, or are you doing more of a anatomic type reverse, so to speak?
I I think that's a great question. I think that there's a lot of work yet to be done in reverse for fracture. I think it's really clear that it works well. I mean, Peter Domos at this year's ASES meeting, not only does it have a better like shoulder outcome than non-offer treatment, it appears to have a mortality benefit. So I think reverse for fracture is, I mean, I think we're gonna look back 10 years from now and say we should have been doing that all along, and why were we ever plating some of those patients that had displaced four-part fractures. But I think maybe more importantly, like, I think we're going to understand that non-offer treatment those patients is really, really negatively impactful that patient's function. I don't know. What is your guys' general approach?
Do you
Anything?
what do you do on the glenoid on that side? Do you lateralize? Do you medialize? Do you do more Kurmasana to optimize tuberosity healing? How are you changing your reverse fractures compared to your normal cuff pterygotrachy reverse?
I'm using a lot of augments in standard reverses, and I don't use as many on reverse for fracture. I think it's nice to medialize a little bit more on the glenoid side there to help to put less pressure on the tuberosity and help to get it to come all the way around. So that's been my general approach. I think what the most important thing for that is I'm just trying really hard to get the tuberosity anatomic and very securely fixated, and that usually requires like 7 sutures going different directions. And it's like every great shoulder case, there's a point in the operation where you're like, if I forget which one's which, I'm screwed.
The fellows draw the suture patterns up on the whiteboard, and then
Right.
halfway through you're like, wait, which one's which? Yeah.
Yeah, or the nurse opens them all the same color, and you're like, no, I need you to open more sutures of different colors. I'm not going to figure it out. Yeah.
I love it. That's awesome. Oh, that's fantastic.
Wait, Dr. Chalmers.
Dr. Chalmers.
Quick question.
Joanne.
Sorry.
Hey, Kira, give Joanne a
Sorry.
chance to ask.
Sorry.
Oh, it's okay. It's okay. I just was gonna go through a couple different scenarios. So for the rheumatoid patient without a cuff, would you say better to do a higher humeral cut, get as inlay as possible with, all configurations, and medialize as much as possible for a active younger male patient with an intact cuff, like not as worried about acromial stress fracture, so better to lateralize to get better impingement free range of motion, and you can still distalize because you're not as worried about the acromial stress fracture, but their deltoid can withstand a little more. Could you just run through a couple of those really quickly for us?
Yeah. Hopefully I can remember them all. So the first one was rheumatoid.
Rheumatoid without a cuff, old lady.
Yeah. Okay. So that patient is like worst of the worst for acromial stress fracture risk. I mean, we showed that in our own study that that's like the number one risk factor. So whatever you can do to preserve that patient's acromion is important. There are so first thing I would say is that's a patient where I would definitely use. I would be more hesitant to use an augment on the glenoid side. I try and not distalize those patients as much. I go a little bit slower with them in rehab. Usually for reverse, I'm like a sling is needed protocol. And for those patients, some of them I'm like, we might consider using the sling as needed so they don't get the reverse and then immediately get into like a lot of activity. And then I don't know if this is the right answer, but for really high risk patients, there are patients I'm talking now about prophylactic plating. And I don't know what the role of that is going to be and when we're going to do that, but I do think that there are patients for whom it may be appropriate in the future. For the second one, it was like a young male osteoarthritis, right?
Yeah, intact cuff.
Yeah. Okay. So that patient's number with
Oh, sorry. Sorry, not completely intact cuff, I guess, but they are because they're getting a reverse.
with a male in a cuff tear, the instability is like my number one. Instability and infection are my number one concerns for those patients.
Mhm.
So there's a lot to talk about on the infection side, but maybe barring all that, on the instability side, I'm tending to put those patients in tighter. So I'm almost always using an augment, and I will. That's a patient where like I will even sometimes put in a larger or a lateralized glenosphere, and it may take using the skid to get it reduced, and I'm okay with that in that patient because their stress fracture risk is very low. So I may be willing to distalize more in that patient since they're going to have probably enough deltoid to get their elevation back to try and get stability, to try and get more stability. I don't know if that's right or wrong, but that's how I'm approaching male patients with osteoarthritis.
Thank you.
It's,
Was there a
it's great.
third one?
Is there another
Uh,
one? Sorry, I don't know if there's no one. I had a quick question, Dr. Chalmers. So for like conjoint tendon releases, I know you guys have done a bunch of those and people do pretty well after. How many are you actually doing a year currently? And I mean, are you assessing that intraop? Like, is that like kind of a surrogate for deltoid tension? Like, is that important, do you think?
I so we published on that, and I do it maybe 3 times a year. Like we'll go back to do it.
Yeah.
I'm not routinely doing it at the time of surgery right now, and
That's
there's
yeah. That's what I mean. Like going back. Sorry. Sorry.
yeah. Um, I do think there's probably a role for doing it at the time of the primary reverse, and Mike Kim showed us that he published a randomized clinical trial. It hasn't published yet, but it was presented at this year's ASCS meeting, showing that patients got better internal rotation and less pain when he did a conjoint tendon release. Again, for the reason I mentioned earlier, that the patients get better extension and therefore get better internal rotation. I'm somewhat nervous about it, and I'm nervous about it because of a patient we had. So this is maybe an outlier, but I think it's an important one to mention with this. So it's a patient with Ehlers-Danlos who developed glenohumeral osteoarthritis, who had a failed cuff repair, and my partner did a reverse, and she was unhappy with the reverse. She had anterior shoulder pain, so he did a conjoint tendon lengthening, and then she became unstable. And then I had to lengthen her like 3 centimeters to make her stable, and then she couldn't elevate her arm anymore because she's so distalized. So she's like unhappy with me, and there's like nothing I don't know what to do. Like there's nothing else I think I can do for that patient. So I think that it makes a lot of sense for like for someone where you're not as worried about instability, but I do think that there's probably an instability risk you can create with a conjoint tendon release because there's less tension on the construct. And then if you create that risk, it becomes very difficult to tension the patient. And I was really worried about neurologic risk with that patient too. And I feel lucky that she didn't get a palsy because if she had, I probably would have just had to take everything out and tell her it is what it is.
Fascinating.
That's interesting. I always see, one of the things that you'll see is that sometimes the conjoint is exceedingly tight when you put it in, and or what their interhumeral kind of distance is to clear when they internally rotate, depending on how narrow it is. But Eric and I have gone to this trial of releasing the pec minor, interestingly enough. I'm curious to see whether or not they get a little bit more rotation out of their scapula to help their range of motion.
Yeah, we're in the middle of that trial right now, Peter. But I was actually wanting to do the conjoint. I didn't realize that Mike Kim had already done that trial. But we did a pec minor because I've done had a couple patients who we did pec minor releases afterwards that had kind of the protraction, anterior shoulder pain or chest pain, some range symptoms, and got better significantly. So we're almost done with our RCT of randomizing pec releases versus no pec releases. But conjoint tendon was attractive to me. I have an N of one releasing one, but it was accidentally by one of my fellows intraoperatively when doing a revision. It was one of the base plates where you have to use the tuning fork to get it out, and he was a bit more aggressive and just basically peeled off the conjoint tendon. And then I just reattached it to the humerus and was like, great, this patient's gonna be dislocating in like, a couple weeks. And I like joked that I was gonna be sending him to let him revise it once the patient started dislocating. And then like a year later, I sent him a video. Patient's internal rotation is like unbelievable and like super happy and has incredible motion. So I was like, man, maybe I should be doing that in all my patients. But I get your point is if you start dislocating, how are you going to tension that patient? That would be super complicated. I don't know.
It makes me
Yeah,
very worried, Wags. I don't know.
yeah.
I'm not sure that I'd be willing to randomize people to that one. The pec minor, I have no problem randomizing. That one, I may draw a line.
Yeah, I don't know.
Dr.
Um,
Chalmers, can I ask a
yeah,
question? So as
yeah, of
mentioned,
course.
like I'm a hand surgeon, and prior to like blessing Gottschalk and Wagner with my presence, I was actually George Athwal and Graham King's partner. So I did a lot of biomechanics work, but obviously it was all in the hand and wrist. So I was just kind of curious because you're obviously very prominent within the biomechanics realm for shoulder. Like there's always criticism for the active motion simulation in terms of like the fact that it's not in vivo. So like for the wrist, like I was able to move, like I still do like obviously the active motion simulation for wrist, and that's where a lot of my research is. But then I also moved into 40 CT to try to get some active motion. Do you envision for shoulder, like what do you think about like radiostereometric analysis for shoulder or FEA in shoulder? Do you feel like the biomechanics research is moving in other areas?
Yeah, I think 40 CT is fascinating, and like I think it's a great tool. I've seen some in the elbow that are like they're unbelievable. They're so pretty.
Yeah. They're
Um,
gorgeous. I agree.
yeah, I we haven't moved into that particular realm yet, but I've been really curious about it. The I mean, if you worked with George at the Hulk, I mean, they do great work there, and they've done just so much amazing biomechanics. So much respect for that lab and the work they've done. So you probably know about more about biomechanics than I do if you worked there. So
Yeah.
yeah.
Yeah. George, for the record, the 40 CT for the elbow and shoulder, they stole that from me. Because they're like, oh, they're such pretty pictures. Then consequently, all of a sudden, I was like, where's my PhD? And they're like, what? Why are you doing that joint? I don't want that joint. But yes, I wasn't sure because it's like that's one of the criticisms. And if you look at like hip and knee arthroplasty biomechanics research, they're moving into that realm a lot more because for longevity and things like that. So for implants, like obviously wrist implants are not as popular and known, but I was curious if that was happening in the shoulder biomechanics world.
Yeah, I mean, there's the RSA studies have been great. I mean, they've done, as far as I know, like the only RSA studies. I mean, like no one else seems to be doing shoulder RSA in the world other than that group. I do think there's a lot of things we could find from it, and I have often thought that it's an underutilized technology. We just don't. I don't have someone at my university with the expertise to do it. And we had the PhD from there on the podcast, and I'm trying to remember the guy's name. But I had him on thinking he was an orthopedic surgeon. He came on and he was like just a guy that did RSA, which was great. He was a great person to talk about RSA, but it made me realize you actually need a full-time person to apply that particular technique.
Yeah, absolutely. Yeah. It's just hard, which is why like when I moved to Emory, it's like the technical aspects of actually executing it is very difficult.
Well, and God bless you for studying the wrist. There's so many bones.
I don't, which is why actually for shoulder and elbow, it's so much easier 40 CT and stuff like that. Very easy to do, actually. Much easier.
Eric told me he's still doing hand surgery. I was like, you got to be kidding me, Eric. The wrist, there's so many
It's
bones. I don't
great.
even remember all their names. It's so complicated.
No. Look, think about all the time, all the blood that goes to your head because you're sitting down. It's wonderful. You should try it. You should try it. I have my obligatory pictures where like before George gets into the room, I'm like scrubbed with his fellows and everything, and the patient set up and beach. Like I have that. I also have pictures of like when George is always talking fancily around the world. I'm in his office. I moved all his awards into my office, and I have pictures of all his awards in my office as well. It's great. But thank you. That was a really great talk.
Well, I'm glad I only talked for a half an hour. There were a lot of questions. That's good. That means it's a good topic.
It's an amazing topic. Well, Peter, thank you very much for spending the evening with us. And yeah, that was incredible. That was awesome. And congratulations on all that great work.
Well, thanks so much for having me. It was really an honor. And I mean, you guys have got a great program. And yeah, I'm going to really, it's a huge honor to have the opportunity to speak for you guys.
Amen.
All right. You guys have a nice night.
I'll see you soon, man.
Okay. Bye.